Hello, and welcome to this episode of the Portion Perfection Professional Weight Management Series, where we bring you strategies from the best minds in the industry. I'm Amanda Clark, an advanced accredited practicing dietitian and the author and creator of Portion Perfection, a visual weight control plan. I've been working in weight management and gut problems for somewhere over 25 years. Today, we're expanding our scope to include irritable bowel syndrome or IBS because it's a condition that we often see amongst our weight management clients generally, whether they just be making dietary change or maybe they've had bariatric surgery. So why the connection? Well, for our bariatric surgery clients, it might relate to changes in gut bacteria over time, or it could be to do with some of the physical changes of the actual surgery itself. For symptoms that exist before or, in the absence of bariatric surgery, it might be that symptoms of IBS impact food choices, which could be leading to changes in body weight, or that IBS is strongly associated with depression and anxiety, and we know that depression and anxiety predispose to weight gain. Of course, it could also be the current food supply is leading to both weight gain and gut problems. We're not going to be able to unravel that link today, but we're going to talk you through the condition, and we're going to focus on an approach to dietary change that has about an 80% hit rate for improving IBS symptoms. My guest for this session is dietitian Madison Bartlett. Madison and I started working together late last year. Welcome, Madison.
Hello, thanks so much for having me on, Amanda. Happy to be here.
Yeah, wonderful. I've really enjoyed your client interaction while we've been working together and the difference you've been able to make in the lives of clients with gut symptoms. How did you get interested in this area?
Thank you so much for that. There's a couple of reasons. Probably the most important one is that I'm an IBS sufferer myself, so I know the impacts that it can have on your quality of life. So I just really want to help other people investigate where their symptoms are coming from and how to manage them. And also, gut health is just such a broad and complicated subject that there's always more learning to do, and new information is always coming out. So it's a really great topic to be interested in because you're just constantly working on it, learning new things. So it gives me a bit of a challenge.
Yeah, and I actually even think that if I had a significant problem, whether it was a gut problem or an allergy or an intolerance problem, I'd actually probably go to see a dietitian myself because although you can kind of figure it out, it's so valuable to have someone say, this is the approach, you're going to do this for this long, this is the record I want you to keep, and then I'm going to look at that record in 2 weeks' time and we're going to decide what happens next. That's really valuable.
Yeah, definitely. I'm just a knowledgeable person to walk alongside with. So
Exactly. And you've done some extra study in this area, haven't you?
yeah, I completed my IBS and FODMAP training with Monash University, which was invaluable.
Yeah, excellent. Okay, sounds great. Well, we're going to co-present some of this content because I think we've both got a valuable contribution to make. So, Madison, I'll hand over to you and let's get started. Okay.
Thank you. So, like I was saying just before, IBS affects not only your quality of life, but affects a lot of people. I see it a lot in clinic. I also hear about it and see it a lot in my friends, family, and on social media as well. It kind of is everywhere. I've never heard of someone who hasn't heard of IBS before. So it is the most common gastrointestinal disorder, with it making up 5% of all GP consultations and 50% of all gastro referrals as well. So there's no actual test to determine if you do have IBS. So we use something called Rome-4 criteria, which is just a set of symptoms that we use to determine if you've got IBS because there's no actual clinical test. So Rome-4 criteria is recurrent abdominal pain at least once a week over a 3-month span, plus 2 of either that pain being related to your defecation or a change in frequency of your defecation, a change in appearance of your defecation, with these symptoms beginning over 6 months ago. So irritable bowel syndrome is very common, and the statistics say that there is at least 1 in 5 sufferers at one given time, which is a very high statistic. We've seen that two-thirds of sufferers are females. We're not exactly sure why. This is just what the evidence tells us. And it says, the statistics say that 30% of IBS sufferers take sick leave, many over 2 weeks per year. So you can see briefly just the impact that it can have on people's life. So these are some of the questions that GPs and dietitians like myself will ask you when you're coming in for an initial consultation with us. Because there's no actual test to determine if your symptoms are caused by IBS, we have to kind of rule out any other conditions that might be causing it. And these conditions can be more serious and life-threatening as well, such as things like inflammatory bowel disease or bowel cancer. So some of these questions involve, are you over 50? Have you had blood in your stool? Have you been experiencing a fever? Have you lost any weight? Do you have symptoms that wake you up in the night? Do you have a family history of bowel cancer? Is there a possibility of ovarian cancer? And have we checked for things like celiac disease, lactose intolerance, and inflammatory bowel disease? So some of the tests that may be ordered when we're asking these questions as well from your GP are things like stool tests, colonoscopies, and blood work. So this is the most common list of symptoms from IBS. So bloating, abdominal distension, flatulence, diarrhea or constipation, and abdominal pain. So if you're experiencing bloating or distension, it can be for a number of reasons. So it could be a solid that is causing your problems. So it may be a buildup of stool in your gut. It also might just be constipation or a blockage, which is causing your stomach to expand. It could be liquids, which could be just be an undigested particle that brings upon liquid, which again extends your gut. It could be excessive gas, or it could be visceral hypersensitivity. So what we see with sufferers of IBS is that some have very sensitive nerve endings in their gut. So you might be experiencing a normal level of bloating, but if you've got a sensitive nerve endings in your gut, it's sending signals to your brain telling you that that bloating is causing you pain and discomfort, whereas really it's actually a normal amount of bloating, but it feels real. So if you come to see me for assistance, I will ask all of these questions to you. So this could be some of the reasons that you're experiencing symptoms, and it can also help me investigate or choose which path to go down in terms of treatment. So I'll ask you if you've had a history of a gut infection or food poisoning. I'll ask you about your stress levels. Stress levels is a really big, has a really big relation to IBS, whether it's the cause of or a result of, or a little bit of both, probably both, but that's a really big indicator and something to think about when we're talking about IBS. Antibiotic use, so that could have a effect on our gut bacteria, which affects our digestion. The location that you're actually experiencing the pain. Foods that you already think might cause your symptoms. So you know your body a lot better than I do. So you might have noticed that, oh, when I eat foods with dairy, it seems to upset my tummy. So I'll always ask you if you've already identified some foods that cause you some problems. And then, of course, I'll ask you about your intensity and your frequency of symptoms. I often get you to rate your symptoms on a scale of 0 to 10, so then we can compare the next time. So I've become very comfortable in talking about poo in my practice, and if you come to see me, you will too. It often starts uncomfortable, but you'll get very comfortable with it. So I'll often bring out this chart, which is a Bristol stool chart, and I'll ask you to identify what types of motions that you are having and how many times a day. This again helps to direct in which direction I'll give you advice in, because each different thing helps a different type of stool. So often this is where I will begin with clients. So I'll ask you a bunch of questions around each of these things, because all of these things have an effect on the symptoms that you may be having. And I like to start here because sometimes it could just be an easy fix of maybe you're eating too fast. Maybe the portions are too large. Maybe there's too much fat in your food. Maybe you have really stressful meal times. Maybe you've got a toddler and a baby, and there's lots of anxiety around mealtime, which then peaks your symptoms. It might be that your fiber intake is too big or too small. You might be consuming too much alcohol or caffeine. And we'll go through each of these things and you'll tell me, oh, I actually have about 6 coffees a day, or oh, I often skip lunch, so my dinner's quite large. And it's a really good place to start because these are sort of the easiest and simplest tricks to use. And sometimes I've seen that it can just be a simple and quick fix, but sometimes we need to delve a little bit deeper if these things aren't relevant to you as well. So these are the main treatments that you have probably heard about and read about. So diet and supplements is where my main role is. Medications is the GP's role. And then the psychology, obviously a therapist or a psychologist to work on that sector of it. So this is some of the dietary treatments. So this is going off a little bit of that list that we had before. So I might be talking about fiber, water, activity. We might be talking about reducing your caffeine intake. We might take you through a low FODMAP diet, which is a little bit more intensive, and we'll talk about that actually a little bit at the end of this webinar. We might need to go on a low carb, dairy-free or wheat-free diet if these things seem to be causing you some problems. We might need to go on a low food chemical diet, such as a low salicylate diet. And we might need to introduce some more probiotic-rich foods, such as fermented foods, or certain fruits and vegetables as well. So this is a list of some of the supplements that I regularly recommend for clients. So probiotics, we can get either through food or we can get through supplements. So probiotics is just helping to either introduce new or build upon what gut bacteria you already have. The more gut bacteria you have and the more diverse gut bacteria you have, we see the improvement in digestion. So that's important. Iberogast, which is a blend of herbs such as licorice, chamomile, and peppermint. And this is shown to relieve stomach pain by soothing some of those nerves in the stomach. And we briefly spoke about it before, but people with IBS can have those sensitive nerve endings in their gut. So this can help relieve the symptoms. Mintec, which is a peppermint oil supplement, and peppermint oil acts by relaxing the smooth muscles in your gut, which again helps to relieve the symptoms of pain and bloating. Bitter herbs. So the bitterness in food actually helps to trigger the release of digestive juices, which again aids in digestion. And then we've got soluble fiber, and I absolutely love fiber as a dietitian. It kind of fixes or helps fix a lot of gut problems. So when we increase soluble fiber, we're helping to slow down digestion, which is really helpful when people are experiencing diarrhea many times a day. But it also helps to add bulk to the stool and soften it up, which is helpful with constipation as well. So helps with diarrhea and constipation. So some of the medications that are commonly used, and these needed to be prescribed by a GP, is medications to slow the bowel, laxatives, anti-gas, stool softeners, antidepressants. So this is helping to address an underlying cause of maybe stress, anxiety, or depression, if that's what we find is the main contributing factor to your symptoms. And then antibiotics, if we suspect that there's a small intestinal bacterial overgrowth, which is called SIBO, antibiotics can help reduce some of those unhelpful gut bacteria. So some of the psychological treatment, cognitive behavioral therapy, which needs to be facilitated by a psychologist, gut-directed hypnotherapy, which often gets me a few strange looks when I offer it in clinic or suggest it. This is actually shown to improve symptoms similarly that a low FODMAP diet would. So it's really effective in treating symptoms. And there's an app called Nerva app, which is becoming increasingly popular, and I've seen it work for a lot of clients. It's an app that gives you a 6-week hypnotherapy course. So it kind of offers meditations for your gut. Introducing exercise and acupuncture and traditional Chinese medicine also can play a role too. So now we're going to be talking about FODMAPs. And if you've heard about IBS, you've most definitely heard about FODMAPs before. So this is a route that I take most of the time with people who have been diagnosed with IBS because it has the most evidence behind it. So FODMAPs is a group of foods, they're large chain carbohydrates, and each of the letter of FODMAP stands for a different group. So FODMAPs are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So a bunch of long-winded names that probably sound a bit daunting at the start, but we'll go through these a little bit more. So why FODMAPs? So when FODMAPs are eaten, they move slowly through the small intestine where they attract water. When they reach the large intestine, gut bacteria use the FODMAPs as a fuel source to survive. The bacteria rapidly ferment FODMAPs, producing gas as a result. So when we eat FODMAPs, we're producing gas and we're producing water. So these events occur in all people, including people without IBS. The difference is that people with IBS have problems with motility. So that's the speed at which contents move through the intestines. And that might be that you've got slow motility or fast motility. Also, people with IBS have a highly sensitive gut wall. They've got those sensitive nerve endings. So that excess gas and water just gets felt a lot more by people with IBS because they've got the sensitive nerves. But now we'll move on to what each of these groups are. So I'll hand over to Amanda to take you through the science of it all.
Yeah, I love this. Thanks, Maddie. So all of those carbohydrates that Maddie identified that fit into that category of FODMAPs are these specific, I guess, chemicals. So fructose, and fructose is the monosaccharide of FODMAP, so it's the M. And so monosaccharide means that it's just a single molecule. And in our digestive tract, if something is a small single molecule, it's the right size to be able to get across into your bloodstream from your digestive tract. So no further digestion is required to get it in there. But usually we need some kind of transport mechanism, something that identifies that in the intestine, actually reacts with it or responds to it and puts it across into your bloodstream. So we'll have a look at how that happens with fructose in a moment. Then we've got something called galacto-oligosaccharides, and that's the O of FODMAPs. And GOS or galacto-oligosaccharides are a whole chain of galactose molecules. So galactose is a single unit sugar, but galacto-oligosaccharides are a long chain of them with a glucose on the end. Then we've got lactose, which is one galactose and one glucose. So this is the disaccharide. So it's the D of FODMAPs. And so essentially the lactase enzyme breaks the galactose away from the glucose. It breaks that bond. Then we've got fructans, or sometimes fructo-oligosaccharides, or FOS, which are a whole lot of fructose molecules joined together with a glucose on the end. And then the polyols are sugar alcohols, essentially maltitol and sorbitol. And they're larger molecules, and we don't specifically have a transport mechanism to get them in, but they seep in by passive absorption, and more so for some people than others. So something I want you to notice there is out of those first four, there is really just three substances. There's the fructose, there's galactose, and there's glucose. And so all of those things need to get out of your digestive system into your bloodstream to be able to be used for energy. So if we focus on fructose, first of all, common sources of fructose are, well, we would say that they're fruits, being apples and pears, and also honey. Honey is straight fructose pretty much. But when we think of fructose, we think, or we know, that all fruit contains fructose, and that's absolutely true. But not all fruit is a problem for people who have fructose malabsorption. And so I want to make that a little more understandable. So apart from apples, pears, and honey, we've also got high fructose corn syrup, which is a common sweetener. It's way more popular in the US than it is in Australia, but it does also appear in Australian food. So it is something to watch out for. So let's have a closer look at that transport mechanism. So typically we've got fructose being transported on what we call a low capacity fructose transporter. And what that is it's like an old-fashioned system where you go and you pick up one molecule of fructose from the inside of your intestine, and you go over to the other side of the cell and you put it into your bloodstream. Then you go back and you get another one. So it's fairly low capacity. It can't take armfuls at a time. And so it does mean that you can overdo it. If it's fruit season and you sit down to a big fruit salad and you give yourself a very large fructose load, that transporter is not going to be able to keep up with the amount of fructose that you've loaded into your intestine. So you can experience symptoms, even when you don't have a particularly bad problem. You can experience symptoms if you over consume fruit in one go. An interesting thing about fructose, though, is that there's another way for it to get in. You've got a very high capacity glucose transporter, and the glucose transporter can take barrow loads or arm loads of glucose, and it also takes galactose and puts it into the bloodstream. So nobody really has a problem with the absorption of glucose because you can absorb so much so quickly. It does happen that people have problems with their glucose transporters, but it would be diagnosed at birth because you really need glucose to be able to get in, to be able to survive. But whenever there's a glucose being transported, a fructose can actually hop on. So that means if you have that large dose of fruit and there was also glucose there, then you're transporting glucose, the fructose can hop on with it, and you end up with no problems. So the problem occurs when you've got an excess of fructose. And so that's really what defines which fruits are a problem and which ones are not. Ones that have more fructose than glucose will end up with leftover fructose because for many people, as we get older, that fructose transport mechanism, the transporter, can break down. And so then we're relying on the glucose one, and the glucose one requires matched fructose for glucose. So, for example, an apple has much more fructose in it than it does glucose. So if you've got a problem with that fructose transporter, or you eat a lot of apples, then there's going to be fructose left over, and that fructose is going to travel down through your small intestine, it's going to arrive in your large intestine, and it's going to be fermented by the gut bacteria and cause you some problems. So fruits that are in balance between how much fructose and how much glucose are in there are quite suitable. So the orange you see there has an equal amount of glucose and fructose. So no problem, because even if your fructose transporter doesn't work, it's going to get across with the glucose. And the banana has a lot more glucose than fructose. So again, there'll be no problem getting that fructose in. So it's not a complete malabsorption of fructose, but it's a malabsorption of excess fructose. Okay, so I'll hand back over to you, Maddie, for galacto-oligosaccharides.
Great. So I'll just go through the rest of those subcategories from the FODMAP group. So we've got the galacto-oligosaccharides. So common sources of these are mainly your beans, lentils, and nuts. So we've got butter beans, peas, pistachios, cashews, whole bean soy, which is something to look out for. So some soy milks are made from whole beans. So you're just going to turn around the packet to have a look where the soy is coming from. And then we've got oat milk and chickpeas as well. Next on the list, we have lactose. So your common sources are all your dairy foods. So milk, goat's milk, custard, yogurts, and soft cheeses are the foods with highest amounts of lactose. So this is just a list of lactose-containing foods, and we can see that some dairy foods have more lactose than others. So milk is sort of your big ticket one. It's got the most lactose, 12 to 16, whereas something like an ice cream might only have 3. We do see that up to 4 grams of lactose per sitting is usually pretty well tolerated. It's just when we start going above that we start getting some symptoms. So you might be able to tolerate some ice cream, but not so much a glass of milk. And soft cheeses are things to avoid, but we can definitely include things like a hard cheddar cheese. Next, we have fructans. So most common source of these is just your wheat-containing foods. So pastas, breads, cereals, cakes, and biscuits. So if we're going to eliminate going through the low FODMAP diet, we can just switch to a gluten-free variety. And then we've got onions, leeks, artichokes, and garlic. Next, we have sorbitol. So common sources are sugar-free chewing gum, also things like apples, pears, peaches, plums, and apricots. And you can notice there that apples was also in the fructose list. So many of the FODMAP groups and foods do overlap as well. And then lastly, we've got mannitol. So common sources are mushrooms, cauliflower, peaches, and watermelon. So this here is one of the original research pieces that showed that symptoms are additive. So we know that each of these subgroups of FODMAPs do cause symptoms, but what we also now know is when we start to add these foods together, we start to see symptoms get worse. So you might have something like toast with some soft cheese on it, and your symptoms might be worse than if you just had a piece of toast with no other FODMAP additive to it. So you can see on the left-hand side, we've got fructan, and our overall symptom severity is about a 55. If we have fructose, it's pretty similar, so about a 55. But if we have fructose and fructans together, the overall severity of the symptoms increases to about 65. So we know that when we start to add these foods together, the symptoms get worse. So when we add these foods together, the symptoms get worse. But what we also know is when we start to have bigger portions of these things, they start to get worse as well. So this graph here is just demonstrating that when we increase the amount, so from 50 mils to 100 mils to 170 mils, the symptoms always grow with increased dose. So the dose and the combination are both important things when doing a low FODMAP diet. So this is the process that a dietitian like myself would take you through. So what we do is we go through a 2 to 6 week elimination trial. So this is where you eliminate all FODMAP foods, which is quite challenging, which makes working with a dietitian really crucial. So you eliminate all of these foods for about 4 weeks. Then you come back to see me and we discuss whether your symptoms have remained the same or whether they've improved. And you'll do that by keeping a food and symptom diary. So if you come back and say, look, my symptoms haven't really changed, they're still pretty bad, I haven't noticed any difference, then we go, okay, well, how well did we stick to that low FODMAP diet? But if you've stuck to it really well and no symptoms have improved, then we kind of go down a different track because we know that nothing improved. If your symptoms have improved, then we go, okay, well, it's clear that something on that list of FODMAPs is causing your symptoms because now that we've eliminated it, your symptoms have gotten better. So that's when we go through the challenge phase. So what we do is we challenge each group of the FODMAP one at a time over 3 days. So how we do that is we go, okay, we're going to start with lactose. We're going to introduce one food from the lactose group. Maybe you want to introduce milk, so we'll choose milk. We do it over 3 days, increasing the dose over each day. So the first day, we might add in a 1/4 cup of milk. You write down your symptoms. The second day, we do 1/2 cup of milk. You write down your symptoms. And then the third day, we do 1 cup of milk and you write down your symptoms. Then we have a 2 to 3 day break before trying the next food. So what you might find is when you come in to see me, oh, well, I had lactose and I had a 1/4 cup and my symptoms were fine. I didn't have any diarrhea. But when I introduced 1/2 cup, I had diarrhea that night. And then when I had 1 cup, I had diarrhea for the next 2 days. So that tells us that, okay, you can tolerate a small bit of lactose, but as soon as we go over that 1/4 cup, we start to get symptoms. So that's where we're reintroducing the foods. By the end of all of the challenges, we should have a list of foods or groups that causes you symptoms, where after that we can start developing our tolerance of how much of that food can we have. Can we pair that with other FODMAPs, or do we start to get symptoms when we add these things on? So then at the very end, we have a known list and amount of foods that cause your symptoms, which isn't to say that you can never have these foods again. It's just so you're aware that, okay, one night I really want to have a pizza, but I know that cheese causes me symptoms. I'm okay with that for tonight, but I'm not going to have it in my diet all the time. So that's the overall process of the FODMAP diet. As you can tell, it's quite extensive and intensive as well. So working with a dietitian is really advised. So this is a sample diet that I might provide you with. So you can see here that we're still getting important nutrients like protein, fruits, vegetables, and fiber. So again, that's why it's really important to work with a dietitian, because it is a pretty restrictive diet where we do get nutrients from some of the foods that we're cutting out, such as if we're cutting out lactose foods, we might be reducing a lot of our calcium-rich foods. So it's important to work with a dietitian to help meet your targets whilst doing the low FODMAP diet as well. So lastly, these are a few resources available to you. So you've got the Monash University Low FODMAP Diet Guide. And we're talking about Monash University a little bit just because they're the developers of the low FODMAP diet. And then to the right there, we've actually created a long list of recipes for low FODMAP that are available for purchase through our website as well. And then obviously Amanda and I are available for consultations, and we would love to work with you. And one of the major reasons to see a dietitian is to ensure that your FODMAP diet is not nutritionally compromised. So during that restriction step, over restrictions of certain food groups, such as the dairy, fruit, and vegetables, may reduce your intake of calcium, iron, fiber, vitamins, or even protein, which can be avoided by seeing a dietitian. We can help develop low FODMAP alternatives that you can enjoy during your diet whilst ensuring your nutritional status is maintained. Your diet is personalized to your needs as well. We can also help troubleshoot if anything comes up during this phase, which they often do. So if you're feeling confused about anything, something strange happens, some weird symptoms happen, we're here to discuss those with you and help you come up with an interpretation of those and a plan forward. And we're also just there as a support. These symptoms have a real effect on your quality of life, which goes hand in hand with experiencing things like anxiety and low mood and stress. So we're here to help you deal with those confusing parts of the diet that come along with that as well. So just being a support, like I said at the start, a knowledgeable support person. So I would love to work with some of you. So feel free to reach out or use any of the resources that we've come up with as well. But thank you so much for having me on, Amanda. I really enjoyed it today.
Yeah, that was great, Maddie. And I guess you'd find, same as I do, that people don't need to actually be in the office there with us, that telehealth is quite good for IBS because there's nothing for us to physically measure or
Yeah.
look at. Um,
Yes, definitely. Doesn't matter where you are, we can work with you.
yeah, so telehealth is good. Maddie, have you got any interesting kind of cases that you've worked with, or indication of how somebody's symptoms changed that you've worked with so far?
Yeah, so one recently that comes to mind, I was working with an older lady a few weeks ago. She was about 80 years old, and she came in to see me, and her symptoms were really severe. She had constant diarrhea all day. She was feeling really anxious about leaving the house, having to Google if there was toilets nearby wherever she went. But really, she would just stay in her house because of how bad the symptoms were. And she'd been experiencing it for over 10 years. So really massive deterioration of quality of life, especially when you're elderly as well. Those social interactions are very important. So she came in and she rated her symptoms a 9 out of 10. And we decided to go down the low FODMAP pathway. And by the end of all of our, by the low FODMAP diet and all of our interventions, her symptoms actually got to a 2 out of 10 from a 9. She was able to leave her house and she was getting in more social interaction, and she just came in with a massive smile on her face. So that was a really big win.
Oh, that's excellent. Yeah, I really think that gut symptoms really play into self-confidence and ability to socialize. If you've always got on your mind, what if something goes wrong, or what if I eat something that causes some symptoms, or what if I can't find the toilets? Yeah, it's a real complicator to having a comfortable social life. Um, yeah. Okay. Well, thank you so much, Maddie, for sharing all your knowledge today. That's been excellent.
More than welcome. Thanks for having me.
Okay. If you find value in these sessions, then please spread the word. I get to attend a lot of professional conferences where I get to meet some of the best minds in the business, like Maddie. My goal is to bring their great ideas along with mine to you. The larger the audience, the greater the interest speakers have in joining us. If you want to support us, check out our products and services at greatideas.net.au in Australia, or on Amazon in the US, or refer a friend. All they need to do is make a purchase or download a freebie from our website, and they'll get onto the invitation list for these webinars. You can find us on Facebook and Instagram too, at Portion Perfection. Thank you for joining me for this very interesting discussion, and I'll see you next time.